Hello, welcome to TCTAP 2021 and our Imaging and Physiology workshop. My name's Bill Fearon from California, and I'm pleased to be co-moderating this session with Dr. Bon-Kwon from Seoul. And we have panelists, Dr. Akiko Maehara, Dr. Hitoshi Matsuo, Dr. Imad Sheiban, and Dr. Frederik Zimmermann, who will help discuss the presentations. I'd like to thank Dr. Park and the organizers of TCT Asia Pacific for the opportunity to participate in this session and welcome you. We will start off with a session called New Insights on Physiology and Special Populations. And kicking off our first talk will be Dr. Javier Escaned from Spain, who will speak about the physiologic assessment of non-obstructive coronary disease. Javier?
Thank you very much, Bill, for this kind introduction. These are my disclosures. Well, the background for my presentation is, of course, ischemia and non-obstructive coronary artery disease, a condition that is associated to this high prevalence of patients presenting chest discomfort with anginal characteristics, but no sign of obstructive coronary artery disease. Typically, this happens in patients who either have angiographically normal coronary arteries or that have a functionally non-obstructive stenosis, that means with FFR, non-ischemic FFR or IFR values, or persistent post-PCI angina. This is a cause of severe impairment in the quality of life of patients and increases enormously the healthcare costs. If you just to give an example of the dimensions of the problem, if you look to this paper by Manesh Patel, reflecting a large volume of studies, coronary angiograms performed in the United States, you can see that even in the best possible scenario, that is having positive non-ischemic test, typical angina pain, you still have more than 45% of patients that when undergoing coronary angiography have no obstructive coronary artery disease. What I would like to share with you today are some of the knowledge shifts in the field that have occurred over the last 10 years. The first one, probably a very relevant one, was moving away from the syndrome X, which eloquently speaks about the surprise of our colleagues in the 80s who were seeing patients who clearly had angina but no obstructive lesions, to the situation that we have nowadays in 2019. Remember that the syndrome X was considered a benign condition because it was a mixed bag of patients, while nowadays, when we have objective evidence that there is something wrong in any of the realms of the coronary circulation leading to ischemia, this entails a bad prognosis. And if you have to choose one study reflecting this, probably the WISE study is a very interesting one because was performed in women and who had angina. And you can see here what is the fate of these women who had no obstructive coronary artery disease. Those who had low coronary flow reserve over the years develop many more events than those that have normal coronary flow reserves, among other, the development of epicardial stenosis. The second shift in knowledge was moving from the concept of having a single physiological test to investigate these two combined tests. Remember that in the coronary arteries, the main function of epicardial vessels is conductance and distribution of blood, and therefore it makes sense that the indexes that we use to assess the presence of abnormalities are conductance tests or relative conductance tests like FFR or IFR. On the contrary, the main function of the microcirculation is the regulation of blood supply that is constantly shifting or varying. And that explains why we use tests that explore the dynamicity of the coronary microcirculation, like, for example, coronary flow reserve, or the tests that explore the inverse of conductance, that means resistance, that speaks about the structural changes in the microcirculation. This was one of the pieces of research coming from our group where we were exploring how to combine in a comprehensive way the dynamicity of the coronary microcirculation with coronary flow reserve, the status of conductance of the epicardial vessels with FFR, and the changes in the conductance of the microcirculation looking into resistance, IMR or HMR. And this was based in an approach also by Lance Gould and Nils Johnson that was tested first in PET. Another shift in knowledge was stop speaking about coronary microvascular disease and focusing more from an operative standpoint in specific endotypes of vascular dysfunction. This trend started in 2017. These are two of the papers, one of them from our group, and basically focus very much on the idea that if you consider the coronary circulation, like with this resistive map, where you see the resistances, vascular resistances associated to epicardial vessels, arterioles, and capillaries, you understand that in these patients you have a specific pathways of dysfunction. First one are vasomotor abnormalities that are affecting the epicardial vessels of the microcirculation. Just to share an example, this is a lady who has stents in the LAD and diagonal branches. She continues having chest pain after PCI. And when we performed acetylcholine infusion, in the first dose that we performed, we don't see much of a change. But when we performed the dose of 100 micrograms, you can see immediately this slow flow phenomenon that runs along with changes in the EKG and development of the chest pain, demonstrating that this lady had microvascular arterial spasm. This is, of course, because in the realm of the microcirculation, large size and small size arterioles are modulated by different triggers. The smaller ones are modulated mainly by metabolic mediated vasodilation, but larger arterioles are actually triggered. The vasodilation is largely triggered by endothelial control. If you have dysfunction at this level, what you will have is microvascular spasm following a stimulus that is actually seeking to have more flow. And this is actually something that happens in many occasions in patients who have also implanted stents in the coronary arteries, like this patient that you can see here, where you also may have vasomotor disorders at the epicardial level. The second big group of dysfunction in these patients with INOCA is structural remodeling of the microcirculation. Now, you can see in this experimental model what rarefaction of the microcirculation is in the micro CT that you see on the top, this model of hypertension. You can see how there is a decreasing density of both arterioles and capillaries. And in the lower panel, you can see thickened arterioles and also changes in the structure of the myocardium, characterized typically in this particular subset of patients by increased fibrosis. In later, Jung-Min will be speaking about the cardiac transplanted heart. This is a study that we performed years ago in cardiac allografts as an opportunity to have the possibility of obtaining biopsies, but before that performing some functional measurements, and we realized that actually both the decrease in capillary density and the increase in arteriolar obliteration that happened in these patients were independently related with the microcirculatory conductance, again, in practice, increase in resistance. Let me show you how this affects patients. This is a patient that has hypertension, some degree of left ventricular hypertrophy, and a positive exercise test with chest pain and development of left bundle branch block during exercise. So we are doing the study in the patient, in the cath lab, we're using a cycloergometer. We monitor flow and pressure. This is the resting EKG. The patient is now exercising, following a Bruce protocol, and I want you to look to the blood flow. This is really interesting. The patient has a starting flow rate of 40 centimeters per second, which is higher than normal. It's about, typically it's about 20 in the LAD or 18, 20. And you can see that as she continues doing exercise, the flow velocity is not increasing. She is now at stage 3 of the Bruce protocol. Blood flow is not increasing. And then at this point, the patient develops angina, and immediately that is followed by left bundle branch block, exactly as it happens during her non-invasive exercise tolerance test. The big difference is that here we are witnessing the big problem that this lady is in, that where her microcirculation is unable to meet the myocardial blood demands. So this is the tip profile of this particular patient. She had also reduced coronary flow reserve. Interestingly, and we understand now, in some of these patients, the fact that coronary flow reserve is due to reduced high flow velocity, but also high resting flow velocity is a marker of this particular endotype. And also you can measure this, like in the patient that you have below, performing thermodilution to calculate coronary flow reserve or the index of microcirculatory resistance. The values that we use nowadays, you have them in this slide, based on studies that have been linked to a prognosis of patients. So for thermodilution, we typically use a coronary flow reserve cutoff of 2 and IMR cutoff value of 25 units. If you're using Doppler pressure, like in one of these patients that you saw, we use a higher cutoff, 2.5 for coronary flow reserve, and hyperemic microvascular resistance value of 2.5 millimeters of mercury per centimeter of second. For the vasomotor endotype, we look to EKG changes in flow and vessel diameter, and also variation of flow from the beginning to the maximal dose of acetylcholine. The final part of my talk is speaking about the shift from cardiovascular events to patient symptoms. The way that we approach treatment in these patients is, if you have a structural remodeling, try to reduce myocardial oxygen consumption, typically with beta blockers as a first drug choice. If you have a vasomotor disorder, if you detect a vasomotor disorder, try to use as a first approach a calcium channel blocker. Of course, always with statins, and in the case of vasomotor disorders, also adding an ACE inhibitor. And then in all cases, consider lifestyle modification and quantification of therapeutic progress with Seattle Angina Questionnaire. The Cormaica study actually tested this approach and actually demonstrated that at 6 months and also 1 year, when this population was followed, it was associated with much better angina control and better quality of life than non-guided treatment. It is still a pending subject to understand if we can modify prognosis in these patients. What we know for the time being, and this is a paper by Dr. Koo and Dr. Lee, what we know in these patients is that if you have the typical patterns, the typical hallmark of a structural remodeling endotype, high resistance and low CFR, the outcomes of these patients in the long term is much worse than other combinations of IMR and coronary flow reserve. And this is probably because, as discussed before, there is a direct relationship of changes in the structure of the microcirculation and concomitant changes in the structure of the left ventricular wall, particularly through in patients, for example, with HFpEF or patients with hypertension, increasing myocardial fibrosis. The clinical practice guidelines from the ESC have reflected these two endotypes and the way that you should approach this with recommendations. And also, this document provides additional information based on the opinions of an expert group. Thank you very much for attention. I look forward to your comments. Thank you.
Terrific. Thank you, Javier. That was a beautiful talk. I think we'll do the next 2 talks, and then we'll have some time for discussion as a group. So our next talk is going to be by Nils Johnson from Texas, who's going to talk about IFR and FFR in severe aortic stenosis patients. Which is better, and are they valid?
Thank you so much, everybody. It's a pleasure to be able to talk about this. These are my disclosures. There's nothing that's directly relevant to the content of this lecture. And I want to begin by saying that the guidelines have historically been quite skeptical about this. If you take a look at what the European document from a couple of years ago had to say, or even the SCI guidelines here in America, it was really negative about using coronary physiology of any kind in the setting of patients with severe aortic stenosis. And really, the Europeans say that we should be focused on angiographic assessment. It wasn't until the more recent American guidelines that came out just at the end of last year and recently published that they started to say that both FFR and IFR are feasible and safe, although they're honest at admitting that there's no randomized trial data in this area to really inform us as to what the goals of care are. And there have been some ongoing or recently completed randomized trials really comparing every possible treatment strategy from simple optimal medical therapy, that is just leaving the coronary disease alone, to doing angiographic guided PCI, as might be suggested by the European guidelines, to doing physiology guided PCI with FFR, IFR. Recently at the PCR valves course, we saw the presentation of Activation, although it hasn't been published yet, which was a trial randomizing patients undergoing TAVI to PCI or no PCI. And interestingly enough, PCI didn't even meet the non-inferiority margin for the primary endpoint, which was death or rehospitalization at 1 year. And in fact, there was a higher bleeding rate in the PCI group, although that was all types of bleeding. And when you looked at just major bleeding, there were no differences. And it's important to note that this trial excluded patients who had severe class 3 or class 4 symptoms. There's an ongoing trial looking at FFR-guided PCI versus optimal medical therapy. This is a study that's being done out of the Scandinavian countries, enrolling just over 450 subjects. And then finally, there's a study out of the Italian group called FATAVI, looking at FFR-guided PCI versus angiographic-guided PCI, enrolling just over 300 subjects. So while we're still waiting for that data, the best I can offer you at the moment is observational outcomes, again from the Italian group that's done a lot of work in this area, showing that FFR-guided PCI provided superior clinical outcomes to angiographic-guided PCI in patients who were referred for TAVI over the subsequent 2 years, largely a result of reclassifying treatment from PCI based on the angiogram to optimal medical therapy based on FFR. And you might be wondering, well, is it safe to perform vasodilation in patients who have severe aortic stenosis? I've put this almost too dense to read table there just to overwhelm you with the data by showing that there's been almost 2,000 patients published in 40 papers in the literature over 3 decades, really showing with a broad range of vasodilators that it is safe to do these kind of studies if one's careful about monitoring hemodynamics, of course. So what does it mean for us to measure physiology, and what kind of things do we have to watch out for? And I would say that this is a fantastic figure that really caught my attention now about 5 years ago from the Italian group, showing a series of vessels where they made FFR measurements before and then immediately after TAVI. And as you can see in the cases that they present here, the FFR value went down. And so, of course, it prompted the question, is this just kind of outliers, or these exceptions, or is this an example of a more general phenomena? And actually, when they looked at their entire cohort, which is the largest single one that's been published of 133 lesions, they saw no average difference in the FFR value before versus immediately after TAVI. You can see that the p-value is not significant. But what they did find was an important interaction. That is, for the lesions with a high FFR value, the ones that are colored there in blue, there was no change. Whereas when they looked at the lesions that had a low FFR value, as colored there in red, and they saw a bit of a decrease. Now you say, well, how often does this happen? Well, 133 lesions, they saw just 8 that crossed the binary FFR 0.8 zone, so that's maybe about 5% or something like that, and just 3 lesions that then switched from the top of the gray zone to the bottom, that is greater than 80 to 75 or less. So they aren't common, but I think it's important for us to try to understand why this is happening so that we won't be surprised when we see it in clinical practice. And in order to understand that, we need to think about the relationship between how the epicardial stenosis interacts with the downstream myocardial bed. And the way to think about that is by looking at coronary pressure curves as a function of flow. And there are really 2 parts to the system. There's the blue curve, which is the stenosis pressure loss flow curve. And then there's the red curve, which is a line and describes the resistance, if you will, of the myocardial bed, although it's not really a resistance because it has both a slope and an intercept to it. And so let's take this hypothetical example. I'm showing you here in the purple curve a fixed coronary stenosis pressure loss curve, and where it intersects the myocardial resistance line, if you will, that's the FFR that we're going to measure in clinical practice, say in this example before we do TAVI. Now, what happens with aortic stenosis are two important changes. The first is shown here in some really elegant animal work in aortic stenosis, is that myocardial resistance line, if you will, shifts to the right in the development of aortic stenosis. And why does this happen? The coronary back pressure, or the coronary zero flow pressure, coronary wedge pressure, those are all kind of almost synonyms for each other, if you will, is very closely related, as you see on the right-hand side, to LV filling pressures. So of course, when we perform TAVI, we immediately unload the ventricle, LV filling pressures fall, and as a result, the coronary back pressure falls, and that takes that myocardial resistance line and it shifts it to the left. So while the coronary stenosis curve hasn't changed at all, the bed has changed its properties, its resistance, if you will, and now it's able to reach a higher flow value, and as a result, the FFR value in some cases can decrease. Over the longer term, of course, there's remodeling of the bed. Again, going back to this very nice animal model, we can see that the line rotates clockwise. That is, there's less flow for the same pressure under conditions of aortic stenosis because the myocardial bed has a higher resistance. And as shown on the right, that resistance is very closely linked to the degree of left ventricular hypertrophy. And that's something I think we understand very well from clinical practice and from a lot of data after TAVI, that the patients who have regression of left ventricular hypertrophy after TAVI are the ones who have the best clinical prognosis, because we've undone, if you will, the adverse consequences of the stenosis itself on the myocardium. And so over time, then what can happen is patients regress their left ventricular hypertrophy as that line rotates because the slope has changed as a result of the resistance. And therefore, again, for the same fixed coronary stenosis, it's able to reach higher hyperemic flows, and the FFR values in some cases can go lower. The reason we don't see this with more mild lesions is because more mild lesions have a very flat pressure loss flow curve, almost a straight line, and therefore are very insensitive to the amount of hyperemic flow that develops. So the FFR values there simply don't change very much during the acute unloading of the ventricle and the more chronic remodeling that happens as LV hypertrophy regresses. Again, this is a very dense table. I just put it out there to show you really the world's literature on hyperemic measurements immediately after a TAVI or SAVR, as well as over the long term, that is the next 6 to 15 months. The top section of the table talks about flow measurements, be it through non-invasive imaging or invasive Doppler wires or mean transit time measurements. The middle section of the table is coronary flow reserve, and the bottom section of the table is fractional flow reserve. And of course, there are small samples and it's a lot of literature, but I've highlighted in red the areas where hyperemia increases either immediately after treating aortic stenosis or in the more long-term period. And you can see that's generally what the literature has found as well. Now, by contrast, the literature has shown us that resting measurements of flow or invasive pressure gradients don't change very much. Again, at the top, resting perfusion or Doppler velocity, and at the bottom, the instantaneous wave-free ratio. And generally, there's been very little change in those measurements, either acutely post-TAVI or in the longer term after these measurements. And so, of course, that comes to the final question then, well, which of these tools should we be using? And can we substitute things like angiographic-based metrics of FFR, for example, QFR or FFR-CT? And again, there isn't a lot of literature out there, so I'm really showing you what has been published. This is a modestly sized series from Japan comparing IFR and FFR against a reference standard of SPECT in patients who had severe AS. And you can see that FFR had a superior diagnostic performance, as you can see from some of the quantitative numbers down at the bottom for the area under the curve. What about substituting FFR then with an angiographic-based assessment, something like QFR, or using non-invasive imaging, for example, FFR-CT? And while those models have been developed and really validated in a general population, over the last year or so, we've had the emergence of several studies trying to apply those tools to aortic stenosis populations, as I've highlighted in red. And of course, the key thing when you're trying to do a substitution is understanding the bias, that is, what is the average difference from the reference standard, which in this case was FFR, and how much scatter or imprecision do you have, as you can see over there on the right-hand side by the scatter plots. As you can see, not only is there more bias as you move away from a general population and into one that has aortic stenosis, but there's also an increase in the imprecision to about 0.1. In other words, if you were to make, say, a QFR, FFR CT measurement and said, oh, it's 0.85, because of that imprecision, it could easily be that the actual invasive FFR value is more like 0.75. And so in summary, I really want to emphasize 2 points. The first, to show in there on the left, is this mechanistic understanding of how the left ventricle remodels immediately after TAVI through unloading and drops in LV filling pressures, and then over the longer term as the left ventricular hypertrophy regresses, and how in some cases that can cause the FFR values to change, even for the same fixed coronary stenosis. And then in very practical terms, what I think that means is if you make an FFR measurement and it's 85 or higher, that's really not going to drop below the gray zone. But in some select cases, maybe a few percent, what you'll see is the FFR values in that 0.80 to 0.85 range may drop below the gray zone FFR 0.75, although we're still awaiting emerging data from randomized clinical trials to tell us what that means clinically. Thank you so much.
Great. Thank you, Nils. That was a terrific talk. We'll finish up this session with a talk from Dr. Jung-Min An from Asan Medical Center, who will speak about the role of invasive physiology in the transplanted heart. Thanks, Jung-Min.
So my topic is a lot of invasive physiology in heart transplantation. Actually, Dr. Bill Fearon is a frontier and the expert in this field. So I have a chance to learn a lot from him. So the heart transplantation started in the 1967 by the Christian Barnard in the South Africa. At the beginning, the median survival is on 1 week, but the median survival has been improved up to the 10 years. But until recent era, the 5-year survival after heart transplantation is only 75%. The patient underwent heart transplantation, received a new heart, but at the same time, patient suffered from the new disease from the heart transplantation. One of those are cardiac allograft vasculopathy. At the late time after heart transplantation, the cardiac allograft vasculopathy is one of the leading cause of death. Combined with gradual failure, so cardiac allograft vasculopathy, also related disease, is the major cause of death at the late period of heart transplantation. Compared with the usual coronary artery disease, cardiac allograft vasculopathy has a very different pathology findings. This is a typical atherosclerosis, the irregular lumen, and eccentric, and positive remodeling. However, cardiac allograft vasculopathy is associated with a very homogeneous location and concentric location and negative positive remodeling, later negative remodeling, and fibrosis, and affected in the intima as well as adventitia and media. Media thickening is one of the major characteristics of pathology of cardiac allograft vasculopathy. So cardiac allograft vasculopathy is initially defined by the coronary angiogram. At 1 year, about 8% of patients suffered from the CAV, and at 15 years, about 80% patient will have the CAV after the heart transplantation. According to the grade of CAV, patient long-term survival is nicely separated. CAV grade 3, at 8 years, almost all patients died. However, coronary angiogram may have the limitation to assess the coronary CAV, so the IVC is more sensitive to detect the CAV rather than more than the coronary angiogram. This is a very important paper. So epicardial coronary stenosis assessed by the IVUS, they compare the maximal intima thickening from the baseline to 1 year. The maximal intima thickening change more than 0.5. They defined as a progression of cardiac allograft vasculopathy. So more than 0.5, less than 0.5, there is a significant difference regarding death and graft loss and death and non-fatal MI. So all these studies about the epicardial coronary artery stenosis. However, pathology study nicely demonstrated that cardiac allograft vasculopathy also involved the microvascular circulation. So this is a biopsy study. They enrolled 873 patients and 9,000 biopsy specimens. They grade the microvascular disease according to the four grades. So grade 3 and grade 4 is a stenotic microvasculopathy. This is very interesting that at 1 year, 68 patients after transplantation has a stenotic microvasculopathy. This number is much higher than the overt epicardial coronary artery vasculopathy. At 1 year, biopsy-proven epicardial coronary artery vasculopathy is only 1.2. So after heart transplantation, more patients suffered from microvascular disease than epicardial coronary artery disease. So according to the microvasculopathy, based on the biopsy, long-term mortality is significantly different. The microvasculopathy is associated with a lower survival rate up to 15 years. Interestingly, microvasculopathy diagnosis at 1 year after transplantation has the lowest survival rate compared with within 1 year. So summarizing the CAV, CAV is a combination of epicardial coronary artery disease and microcirculation, but epicardial coronary artery disease may be assessed by the IVUS easily visualized, but the microcirculation is assessed by only the physiological studies. So the physiological study is important in the management after heart transplantation. This is a pathologic and physiological comparison in the microvascular dysfunction in heart transplantation patient. Yes, this is Javier's papers. Yes, some pathology findings, the density of capillary density or the arterial obliteration is nicely correlated with the physiology parameters. In this field, Javier Fearon is a pioneer, so he studied a lot of studies. PITA-2 studies, he enrolled 25 patients. The follow-up at baseline 1 year, complete physiology evaluation, FFR, IMR, and CFR. Between the 1 year baseline and 1 year, FFR is significantly decreasing, IMR increasing, CFR no change. CFR is a combination of FFR and IMR. It is easily conceivable that no change. FFR is decreased primarily due to the progression of epicardial coronary disease. Another reason of decrease of FFR at 1 year is due to recovery of microvascular dysfunction. So the suboptimal hyperemia changed to the optimal hyperemia at 1 year. IMR is increasing, so the microvascular dysfunction is improving at 1 year, recovered from the immediate post-op damage and higher immune reaction at early period. So the early IMR measurement or physiology measurement can predict the cardiac allograft vasculopathy. The initial period, baseline measurement after heart transplantation, if IMR is more than 20, the subsequent progression of plaque volume is more significant than the IMR less than 20. In addition, the early measurement of IMR can predict acute rejection. At baseline, IMR is less than 16. It's associated with a lower risk of subsequent acute rejection. So the IMR is less than 16. The 1 year acute rejection rate is only 3.3. In addition, the coronary physiology after heart transplantation can predict patient long-term mortality. He enrolled 74 patients heart transplantation. He measured the FFR, IMR, and compared the long-term mortality. FFR at baseline, FFR more than 0.90 is associated with long-term mortality. FFR at the baseline suggested that donor heart, the coronary atherosclerosis, at 1 year IMR more than 20 is also independently associated with the long-term mortality. So physiology study after heart transplantation can assess the risk of acute rejection, coronary arteryopathy, and long-term mortality. In addition, it could be a monitoring for the drug treatment. One randomized trial showed that according to the different assigned drug, the 1 year the physiological marker is changed. In addition, the regression and progression of IMR is associated with long-term mortality. However, the above-mentioned studies enrolled only less than 100 patients, so we have the firm evidence we need more patients. So William Fearon and other investigators try to collect the available data globally, so that nowadays we can gather the 300 patients from the five prospective studies from the 4 heart centers in the 4 countries. Nowadays, almost completed data. So I like to show the preliminary analysis from this registry. In this registry, patients assessed by the FFR, IMR, CFR at baseline at 1 year, FFR, IMR, CFR. So this is an overall change of physiology and imaging, show that is current change in epicardial and microvascular dysfunction. Look at the right slide, plaque volume increasing from the baseline to the 1 year, lumen volume according to shrinkage, but the vessel volume also shrinkage, so the no positive remodeling, but the negative remodeling after the heart transplantation. But interestingly, coronary physiology showed that FFR is no difference, but IMR improved a little. The CFR improved, significantly improved between the baseline and 1 year. This is the instance of abnormal coronary physiology. At baseline, the 5.1% of patients have low FFR, 18.9% of patients high IMR, the 27% of patients low CFR. So overall, the 39.2% of patients showed abnormal coronary physiology. At 1 year, FFR of normal is 4.2, IMR 12.4, CFR was 16.0. Any abnormal coronary physiology is 26.1%. So at 1 year after heart transplantation, one over 4 patients have abnormal coronary physiology, including epicardial microcirculation. So how is this patient long-term prognosis? If a patient have any abnormal physiology, at least one abnormal physiology is associated with a significantly higher rate of death and rehospitalization at 1 year. So this shows the same trend in the subgroup of FFR and IMR and CFR. 70% of patients have the abnormal physiology. I look into in detail according to the significant epicardial disease and microvascular dysfunction. Among the 70% of patients, microvascular dysfunction only is 82.9% of patients. Significant epicardial stenosis involvement is only 17.1%. So according to the epicardial and microcirculation, we classify the 3 groups compared to the normal group. The microvascular dysfunction population and presence of significant epicardial stenosis population was associated with a significantly increasing risk of death and heart transplantation at 10 years. Interestingly, physiology at baseline, there is no association with death and heart transplantation at 10 years. So what is the role of a physiology study after heart transplantation? Actually, this is a contemporary guideline for the management after heart transplantation. The coronary angiogram IVUS is a class 2 indication, but I think FFR measurement, IMR measurement, CFR measurement did not provide additional harm, but give us a very important prognostic value for patient after heart transplantation. This is my summary slide. The CAV is a leading cause of death after heart transplantation, involve the coronary microcirculation and epicardial coronary artery. No conventional imaging allows direct visualization of coronary microcirculation. Coronary physiology study has a pivotal role in diagnosis of microcirculation dysfunction after heart transplantation. Abnormal coronary physiology about epicardial and microcirculation coronary system, particularly at 1 year after heart transplantation, is associated with a higher risk of death and retransplantation. For the management of transplantation recipient, invasive coronary physiology may have important clinical roles in prognostication of patient and subsequent individualized treatment. Thank you for your attention.
Terrific. Thank you, Dr. An. That was a beautiful lecture. It looks like we have about 10 minutes for discussion before we have to turn to the next session. So I thought I'll start with a comment and question for Javier, but then I'll ask Dr. Matsuo, if you don't mind making a comment or question to Nils Johnson about his talk, and then perhaps Dr. Zimmermann, if you can make a comment or question about Dr. An's talk. So first, Javier, that was a beautiful discussion that you led on INOCA, and very interesting. And I wanted to ask you about one of the concepts, the very important concepts that you raised about the different endotypes. As you mentioned, we're learning so much about the microvasculature, and it's not a simple black box, but there's multiple contributing factors. And in particular, you showed the case of the patient with the low CFR and the high resting flow. And this is a very interesting endotype that we see. And I guess my question for you is, what do you make of that type of patient? Do you think, I mean, clearly those patients with low CFR that have high resting flow, a number of studies have shown worse outcomes. Is it a reflection of the type of patient, meaning their age and risk factors that leads to the high resting flow? Is the high resting flow a marker of microvascular dysfunction, or is it sort of a red herring that leads to the low CFR? How do you put that all together? I know that's a complicated question, but I wonder what your opinion is.
Yeah, thank you. Well, it is a subgroup of patients that we are learning a lot. So traditionally, having a high resting flow was considered the Achilles heel of coronary flow reserve, and it was considered, a pitfall basically, or something that was misleading. But now we are seeing, of course, that there are many pathological contexts where actually you may have a high resting flow as indicative of something that is going wrong. One of them, of course, typically the one that we know more is chronic kidney disease. For example, patients with chronic kidney disease have high resting flow. Typically, when you measure coronary flow reserve, we know that these particular patients have a type of hyperdynamic status. But it may also reflect sustained adrenergic drive, for example, which is, can be a marker of worse prognosis in different conditions. So I think that in the patient that I shared with you, probably the combination of having mild left ventricular hypertrophy on one hand, and the fact of having a very impaired conductance of the microcirculation may explain, that this heart was really in trouble from the very beginning. And you could see that the margin of improving coronary flow in exercise was very much limited. So in summary, it's a subset of patients that we, of course, it's a mixed bag for sure. And there will be the percentage of these patients in whom, if you will have repeated the measurement when the patient is more quiet or whatever, you might have a lower resting flow, but it's something that we have to pay attention. For practical implications, for example, now that we are performing all our patients acetylcholine testing and coronary flow reserve, etc., if we are performing acetylcholine testing first, for example, we perform some flow measurements at the true resting stage. And when we perform later coronary flow reserve, we ensure that the resting flow is exactly the same that we had before acetylcholine testing. Otherwise, we wait. And if we are not able to come back to the original flow because, that was triggered because of chest pain or whatever, we take the resting flow that we took before acetylcholine testing as our reference.
Great, thank you. Dr. Matsuo, maybe you can make a comment or question to Dr.
Yes. Recently, we realized that the understanding of the mechanisms of the INOCA is very important. But let me ask one very practical question. In your cath lab, who is a candidate for the assessment of non-invasive assessment of such kind of diagnostic test? I mean, there are many patients who have the chest pain, who complain of chest pain without any coronary artery disease. Can you tell me the indication of the this types of the diagnostic test? Because we tried to find out the acetylcholine test and coronary flow reserve test, but it takes a very long time. How do you manage the cath lab work for?
Well, I mean, just starting with the end, if you really have integrated this into your workflow and you are ready to do it as part of a diagnostic test, it doesn't take that long. I mean, it may add, 5 or 10 minutes, which, by the way, is peanuts compared with the problem that these patients face if you are not finding a diagnosis. So now, typically, the second aspect is that, this is now a way of bringing physiology out of the cath lab. It is now the clinical cardiologists, the ones who are requesting this to us. So in many occasions, they have some evidence that these patients have an abnormal positive exercise test or an ischemia test. But in some patients, they have a clinical impression that this patient is really having angina chest pain. So I think that exactly with FFR or IFR, I think that what you have to do in the cath lab when one of these patients comes is to be ready to provide an answer or a solution to what is happening to him or her.
One other question. Sorry. One more question, a very brief question. Do you have the role of the non-invasive test for the diagnosis of INOCA? Can you have some comment?
No, I mean, there is a peripheral artery tonometry, for example, that is a technique related to plethysmography that you can try to use to check if there is systemic endothelial dysfunction. But the correlation between these two is very, very close. We are performing now a study on post-COVID new onset chest pain. We have already a series of patients, and we are now launching a big study on this particular topic. And we believe that in this particular subset of patients, where probably there is a closer relationship between endothelial dysfunction and the development of new onset chest pain, in this situation, perhaps there is a closer relationship between peripheral arterial tonometry and coronary endothelial dysfunction.
Thank you.
Hey, Bill, can I ask Nils a question real quickly?
Yes, please.
So,
thanks.
I found your talk really fascinating, Nils. Is there a degree of aortic stenosis that, affects the FFR prior to treatment of the aortic valve? Is it a continuous kind of thing as the gradient, transvalvular gradient gets worse? The FFR values, are progressively, higher or lower, or is it just only for severe aortic stenosis? I mean, obviously, in this sort of dichotomization world, we always think about the gradient of 40, but I imagine that there's probably a spectrum.
Right, and as you can see from the animal data that Dirk Dunker did in the past, it's really related to the two features that are consequences of it, and that's elevated LV filling pressures and marked left ventricular hypertrophy. So actually, those are the pieces, not the aortic stenosis itself, but rather the consequences on what's happening in the LV for the filling pressures and how thick the myocardium is. So there are other conditions as well that have the potential to do that. For example, to state an example that has another case for very dramatic myocardial recovery, you've probably done cases occasionally where you make an FFR measurement and someone has very marked myocarditis, and you almost see no vasodilatation at all. The rest PDPA and the FFR are almost identical. And sometimes I've studied those patients after they've healed because I thought, boy, that plaque looked much more dramatic. And indeed, as the myocardium recovers and can vasodilate, that's when you see the drop. So this notion that myocardial changes, be it from doing SAVR or TAVI or recovering from myocarditis or other scenarios like that, have the potential to alter how much hyperemia you can induce. But it's not the AS valve area that's doing that per se. Different people hypertrophy to different extents.
Great. Maybe with just one last, I just want to give Frederik Zimmermann a chance to comment and make any question to you, Dr. An. Frederik?
Congratulations, Jung-Min, with this excellent presentation and also collecting all the data with, as you showed, a database of more than 300 patients, almost 4 times as big as the second largest cohort to date. So my question is, you showed the you used the traditional cutoff values of FFR and IMR, and as it is probably a completely different disease with the allograft vasculopathy, do you think it's more reasonable to also test other cutoffs, or what's your idea?
Yes, yes. Thank you very much for very important questions. I think that actually, frankly speaking, we need to further study to make a cutoff value of the physiology parameters in patients with the heart transplantation, because the condition is very different between the normal patient and heart transplantation patient. But I presented according to the conventional cutoff value because it would be easy to understand what it happened in the heart transplantation patient. But definitely we need further study for making the cutoff value for heart transplantation.
Okay, maybe one small additional question. So you clearly show that it's possible to predict a patient at higher risk. But I think probably a key question is, do you think it's a modifiable risk? You already briefly showed the ACE inhibitor trial, but do you think different immunosuppression or things like that could use, or what's your idea for a future study?
Yeah, that would be good questions. But yes, but recently we have some data about the microvascular dysfunction in heart transplantation could be modified by some treatment. For example, intensive statin therapy can change the microvascular dysfunction. In addition, William Fearon published the data of ACE inhibitor trial, ACE therapy, to improve the microvascular dysfunction after heart transplantation. So all microvascular dysfunction cannot be the modifier factors, but some proportion could be modified by some medical treatment, I think. Thank you for your question.
Great, thank you. We're running short on time. Thank you for those great talks to the speakers and the comments, and I'll turn it over to Dr. Koo to introduce and lead the second part of this imaging and physiology session.
Okay, so thanks for the great talks and active discussion, and now let's move to the imaging field. So that the first speaker will be Dr. Sunil Rao from DCRI, and he's going to talk about the practical application of imaging in his cath lab. Sunil, please.
Yeah, thank you very much. And I have thank you very much for the invitation to TCTAP. I hope next year we can all do this in person. I have the privilege of talking about how I adopted intravascular imaging into my practice, which is really not a very data-heavy talk. So this is kind of a fun lecture to give about how I changed my own practice. These are my disclosures. I've had no consulting relationships with industry since March of 2018. So, the thing that drove our adoption of intravascular imaging in our cath lab was really the need to change. And it's these two quotes that I think apply to the way we're evolving our practice. Slowness to change usually means fear of the new. And I think that in interventional cardiology, where the data are constantly evolving and changing, you have to continuously evolve your practice and adopt new techniques and new procedures and new approaches to patients to get the best outcomes. Otherwise, the quote that's below it will apply. You have to change before you have to, because in this, especially in the United States, where we've got people who are looking over our shoulders and examining our practice, if you're not adapting quickly to the environment and adopting new techniques, you are likely going to be left behind. So to tell you a little bit about myself, I finished fellowship in 2004. And it was a very traditional training program. It was all femoral. I did a grand total of 2 transradial cases, only completed 1 successfully, did 1 case of intravascular ultrasound, did 0 FFR cases during my fellowship. And I joined the faculty in 2004. And since that time, you can imagine how much has changed in interventional cardiology. And certainly my own practice has evolved quite a bit. So there are a couple of things that I think has changed in my practice, and I'll take you through the first one, and then of course the second one, which is the adoption of intravascular imaging. The first was a conversion to radial access. We converted our practice to radial access in about 2006. You can see the growth of radial approach in our practice over time. And in 2013, we've been over 90% radial in our lab. So that was one of the major changes that we made to adopt radial access as a response to the data that were continually coming out showing that it was a more efficient way to practice, and certainly the beneficial effects for patient outcomes with respect to bleeding and vascular complications, and certainly patient satisfaction. Now, the other thing that caught our attention over the years was this gradually growing body of evidence around intravascular imaging. You all are familiar with this trial, the ultimate trial, showing that in complex lesions, particularly long lesions, the use of intravascular ultrasound versus angiography was associated with a better outcome at 3 years. But interestingly, also it was not just the use of intravascular ultrasound, but the response to what you're seeing in those images to achieve what is so-called an optimal result with respect to stent apposition and stent expansion. So if you had optimal PCI, you had the lowest rate of target vessel failure at 3 years. We found these data to be quite compelling because just like every other cath lab probably around the world, the types of patients that we're seeing coming through our lab are becoming more and more complex, lots of surgical turndowns, lots of comorbidities, very, very diffuse coronary disease. And in order to achieve the best outcomes, we thought that this would be a good way to actually improve patient outcomes. Now, one of the things that's happening in the United States is that there has been a shifting, or there will be a shift of PCI away from the hospital setting. So now the major government payer for medical care in the United States, the Center for Medicare and Medicaid Services, has approved the performance of coronary intervention in freestanding ambulatory surgery centers. Now, this obviously creates a lot of issues around maintaining quality of care and in particular safety for patients. So SCAI, the Society for Cardiovascular Angiography and Interventions, has issued a position statement on what types of procedures should be done in what types of PCI should be done in that ambulatory setting. And the reason I bring this up is that if you're going to do procedures in an ambulatory surgical center without cardiac surgery backup, where the patient can come in, get a procedure, and go home the same day, you have to have techniques and procedures and an approach that is going to provide the most reassurance that the patient is going to have a good outcome and not suffer an adverse event. Now, I want to show you something. This is when we started adopting what we called optimized PCI. This is a case done by my colleague, Jen Reimer. This is a patient who had a non-STEMI, had small arteries, and so underwent femoral access via ultrasound guidance. He had a history of a PCI at an outside hospital a year prior and received a 3/0/18 drug-eluting stent to this proximal right coronary. And now you can see after initial balloon dilation, first of all, the stent wasn't placed very well. It was protruding into the aorta. You can see that. After predilation, you can see how woefully underexpanded that stent is just by angiography. Really remarkably underexpanded and opposed, and really not very well sized. And the imaging was not used in the initial procedure. So she proceeded to do intravascular ultrasound to demonstrate how poorly expanded and opposed and undersized that stent was. And then went ahead and appropriately sized the stent. And you can see that a very good optimized PCI result there. So this is, I'm sure all of you have very multiple examples of this in your own practices, because you're all getting patients from all over the place in your own practice seeing probably poorly done PCI. Now, the second thing that I think really helped us was better tools and better technology. So we actually received approval in our Veterans Hospital lab to get OCT with co-registration. This totally changed our practice because it allowed us to actually integrate imaging into our workflow. And I think Javier said this during the last session, which is that if you can integrate these tools into the way you're normally doing your procedures, it doesn't take extra time and it becomes just part of your routine work habits. So this is exactly what happened with this, and the co-registration technology was really very, very helpful and really allowed us to integrate this. So it's not just about changing the attitude to adopt what the new data are, it's about having the better tools and getting them integrated into your lab and into your workflow. So this is the growth of imaging at our institution. You can see in fiscal year 2019, the first 3 quarters, there was basically 0 imaging. By the end of that fiscal year, there was about 12%. There was some growth in fiscal year 20 that really took off towards the end of that year. And now 80% of our PCIs are being done using imaging guidance. We hope that that's going to continue to grow, particularly as we see more and more complex patients and more of our operators are becoming familiar with the technology. But again, it's not just about using the technology, it's understanding what you're looking at and reacting appropriately. So these are what I would consider the 5 contributors to adoption of imaging. First of all, it's the data, right? We want to be evidence-based. We want to follow the data. These data continue to evolve. Ziad Ali is leading the Illumian 4 trial. That'll give us a lot of information. For me, it was really about being humble and admit that I actually did not know how to use these tools and how to react to what I was seeing and how to interpret the images. So I actually went to a course to learn how to do this, and I continue to rely on colleagues around the world, many of whom are on this particular conference, to understand how to interpret these complex images sometimes. Certainly the technology helps, and the technology is incredible now, particularly with the artificial intelligence algorithms that are in the OCT imaging workflow. Education and training, like I said, I leverage the community. We've trained the cath lab staff because they know how now how to set this up, and they do the measurements for us. And of course, consistency. Use this on every single case so that you can get proficient with it. So in summary, imaging-guided PCI is the evidence-based approach to coronary intervention. But adoption requires commitment, training, and consistency. It's important to train yourself and the cath lab staff. And I think this will allow you to make sure that you never finish a case with any uncertainty. And that's going to become more and more important as PCI moves from the hospital setting to the outpatient setting. So thank you very much for your attention. And again, I appreciate the invitation to TCTAP.
Thanks, Dr. Rao, for the elegant presentation. So we're going to have a Q&A session in the end of this session. So that the next will be from Dr. Takashi Akasaka, and he's going to talk about the imaging-based treatment of calcified lesion. Professor Akasaka, please.
Okay, thank you, Professor Ku, for kind introduction. My talk today is imaging-based treatment of calcified coronary artery disease, right? So this is my disclosure slide. And as you may know, there are lots of modality to detect the calcified lesion, but the IVUS and OCT is very sensitive. But compared with IVUS, OCT can evaluate the thickness of calcium, as shown in this slide. And this is the comparison between OCT and IVUS, and as shown in this slide, OCT may have some advantage compared with IVUS because we can measure the thickness of calcium using OCT. But the reality is a little bit different because compared with OCT, IVUS is much more sensitive to detect the calcium because IVUS can detect the deep calcium as well, but OCT may have some limitation in the penetration. That is the reason why we have to focus on the calcium as shown in this slide. Compared with no severe calcification, in case with severe calcification, the prognosis is very worse as shown in this slide. And this is another trial compared with no calcium. Severe calcification demonstrate worse prognosis and much more MACE as shown in this slide. Why this happened? Because even in circular calcium, if it is very thin, we can dilate using stent as shown in this slide. And if even if thick calcium, it is very focal, we can dilate very well. But if there are thick calcium, if you put the stent directly, we may have the under expansion as shown in this slide. And another reason is if you push the stent in the severe calcified region, there are some damage of the coating of the stent as shown in this slide. This may cause the worst prognosis. right? Let's demonstrate a case. This is the colon cancer patient. The patient will have an operation, but she had effort angina. Surgeon sent this patient to our lab, and as shown in this slide, there are very tight stenosis in the mid-LAD and with severe calcification. We cannot pass any device, therefore we did the rotablator with 1.5 bar, and this is a result. After 1 bar, we can make an image with an OCT. There are very clear ablation findings, and still there are thick calcium. Then we size up the bar up to 2.0, and we can get a much bigger lumen area. But here we have no calcium. If we upgrade the bar size more, we will have the problem. Therefore, we did a drug-coated balloon inflation and finished PCI, because patient will have the colon cancer operation, and that might be a problem. Therefore, we avoid to put a stent, and patient prognosis is very wonderful. This is another case, HD hemodialysis patient. The patient had a CABG, and recently he had an angina. The angiography demonstrated diffuse calcium and tight stenosis in one region in RCA mid portion. And we did IVAS first. We can identify a lot the presence of calcium, severe calcification. However, we cannot identify any thickness of calcium. Then we did an OCT, as shown in this slide. There are lots of calcium, diffuse calcium, and some parts are circular, and some parts are very eccentric. And this is a still frame. This is a nodular calcification and circular calcium, and therefore we did an rotablator, and we can confirm the ablation portion as shown in this slide. And then the thickness of calcium less than 500 micron. Therefore, we did high pressure ballooning, and we make a crack as shown in this slide. Fracture of the calcium plate. It is very important to obtain a good stent area, and if the thickness of the calcium less than 500 micron, we can make a crack as shown in this slide, and then put a stent, and after a high pressure ballooning, we obtain a good stent area as shown in this slide in this case. So how to speculate the best cutoff of the making calcium plate fracture? In our experience, about 500 micron, we can speculate the calcium fracture by a higher pressure, or a cutting balloon or scoring balloon. And if you succeed to make a calcium fracture, we can obtain a bigger minimum stent area and good stent expansion, and also the less binary stenosis and less target lesion revascularization compared without calcium fracture. And this is another data from Japan. They did the similar study with a scoring balloon, and the best cutoff to make a calcium fracture is around 500 micron, similar result. And the problem, another problem, is an eccentric calcium. This is a very eccentric calcium, just the opposite side of the diagonal branch. If you put a stent here directly, the carina shift may make some trouble in the diagonal orifice. Therefore, how to treat this deep calcium is the big issue in this case. So we did an orbital atherectomy with slow pullback, and then to confirm the ablation portion. We can confirm the ablation because of the wire bias, and then we did another high-speed pullback, and then we can ablate very ideally as shown in this slide. Then we dilate using a bigger balloon and make a calcium fracture, and we can put a stent, and the final result is ideal as shown in this slide. And Dr. Fujino and their group tried to make a scoring system with a calcium angle and calcium thickness and calcium length. If the angle is more than 180 degrees, they put a 2 point, and more than 500 micron, they put a 1 point, and more than 5 millimeter length, 1 point. And if the point is 4, the poor prognosis can be expected. Therefore, we have to do some region modification with an ablation or a shock wave recently. And this is the one of the recommendation. OCT is very wonderful to decide how to treat the calcified lesion. If the calcium score is less than 3, you can use a non-compliant balloon, scoring balloon, or cutting balloon. But if the score is 4, if balloon crossable, you can use a shock wave. But if the balloon is uncrossable, we try to do the ablation using a rotablator or orbital atherectomy. And then it is very important to make a calcium fracture. After a confirmation of the calcium fracture, you can put a stent, and will get a good result. And yes, and in case with a circular calcium, the rotablator is an ideal modality to make an ablation. But in case with an eccentric calcium, the orbiter it might be much more useful. But it is important to confirm the wire bias. And I do not have enough experience of the shock wave, but the shock wave may change our practice, especially in case with a circular calcium. Shock wave makes a calcium fracture, as shown in this slide. And this finally I try to touch about the nodular calcification or calcified nodule. And in this paper, they randomized the rotablator group and no rotablator group, but there are no significant difference in the finally. They divided 5 different types of the calcium, but it is not depend on the type of the calcium. But in this case, another report, non-calcified calcified nodule. But I'm wondering, in these two papers, nodular calcification and calcified nodule both are including, so not differentiate clearly. But in case with non-calcified nodule demonstrate worse prognosis, as shown in this slide. Therefore, at the moment, we can treat well the superficial calcium plate very well using a rotablator and shockwave. But the problem is a nodular calcification in the near future. So this is my take-home message. In case with heavily calcified lesion, rotablator with small bar size would be recommended. If any imaging device could not be passed through the tight lesion, OCT may allow us to demonstrate clearly the position and distribution and the thickness of calcium, although IVAS might be more sensitive to detect the calcium than OCT. The lesion modification and the site and degree of ablation can be clearly observed after a rotational or orbital atherectomy by intracoronary imaging. Step-by-step change in bar size and rotational speed would be recommended for ablating calcium safely using wire bias. Calcium plate fracture can be made by high-pressure ballooning with non-compliant or scoring or cutting balloon if the thickness of it becomes less than around 500 micron. Enough stent expansion and less instant restenosis could be expected if calcium plate fracture can be obtained after high-pressure ballooning following step-by-step calcium ablation by atherectomy. Thank you very much for your kind attention.
Thank you, Professor Akasaka, for the wonderful presentation and sharing the very educational cases. So now it's time to invite the last speaker of this session, Dr. Jihad Ali from Columbia University, and he's going to talk about the severe chronic kidney disease cases. Jihad, please.
Thank you very much, Bon-Kwon. I'm going to talk to you about imaging-guided PCI and optimization in patients with severe chronic kidney disease. These are my disclosures. So this is a genuine problem. Cardiovascular disease accounts for about half of all the deaths with a known cause in patients with advanced chronic kidney disease It's the leading cause of death after renal transplantation, which is obviously a major societal resource. And there's very little data because almost all trials exclude patients with advanced chronic kidney disease and dialysis from clinical trials. And as a result, understanding these patients is particularly difficult. So I want to introduce you to this concept of renalism. And I pardon the analogy, which makes it similar to racism, and that is that patients with advanced chronic kidney disease, even when they have a clinical indication for undergoing invasive coronary angiography and in fact PCI, don't get invasive strategy performed. The reason is because of the fear of inciting dialysis and kidney injury. So in this study, you can see, which is very large numbers of patients, that patients who have CKD are much less likely to undergo invasive therapy than those patients who do not have CKD. And renalism is true even in the most contemporary of clinical trials. On the left side, you see that patients in the ischemia trial who underwent revascularization, who had a clinical indication for revascularization in the non-CKD group was 80%, but in the patients with CKD, an astonishing only 50% of patients who had met criteria for invasive therapy actually got invasive therapy by either PCI or CABG. So if you go ahead and look at the revascularization to catheterization ratio for patients in non-CKD, it's almost 80%, but the revascularization to catheterization rate in patients with advanced CKD, it's near 50%. So clearly there is a systemic bias towards these patients. And if you go ahead and look in more granular detail, the reason is this, because early on, after you undergo an invasive therapy, your risk of going into dialysis in the short term is higher. And this is very pervasive. As a result, people want to avoid their patients going dialysis. And instead, what happens is we see these curves meet much later on, and you can imagine what happens in the quality of life in this area here. The morbidity of renal injury is substantiated by studies which show that those patients with CKD who develop contrast-associated acute kidney injury do particularly badly. This is 25% effect in one study. And you can see even those patients who don't have CKD who develop contrast-induced nephropathy do particularly poorly. So what are the potential management strategies? Well, there are ones like using Divart and renal guard. These are currently being investigated. N-acetylcysteine has failed, sodium bicarbonate has failed, isoosmolar contrast has failed. So what do we have? We have hydration. This is the Poseidon study from Somjot Brar. Now, important things to remember in these patients is the mean eGFR is 49, not 15. So managing patients with an eGFR of 15 is very, very different to that with an eGFR of 50. The reason is many of these patients come to the cath lab with EDPs in the 20s. And as a result, aggressive fluid hydration can have morbidity effects by leading to pulmonary edema and potential volume overload. What works? This is probably the only study which shows that IVUS can significantly reduce the amount of contrast that you use and as a result potentially impact patients' outcomes. So the first thing you need to do from a practical point of view is learn how to do ultra-low contrast diagnostic assessment. You'll notice that I don't call this diagnostic angiography, and you'll see why in a second. So what is ultra-low contrast angiography? If you define the contrast volume to eGFR ratio of less than 1, you'll see in this study on these spline curves that you have a significantly low risk, both adjusted and unadjusted. So if we stick to a contrast volume to eGFR ratio of less than 1, our risk is lower than if we go above that level. And that means that if we need to use, if we have an eGFR of 10, for example, that we can dilute contrast, we used to do this, we've kind of limited this now, you only need a set number of projections in the right coronary artery and iliocranial, in the left coronary artery and AP cranial and AP caudal, and the LV EDP used to guide hydration. So again, remember, patients with CKD 4 or 5 frequently have elevating filling pressures prior to cardiac catheterization. Thus, pre-PCI hydration in these patients is not recommended. So this is quite contrary to what we normally do. What we do is we bring the patient into the cath lab, and the first thing we do is measure the end diastolic pressure. If the patients have normal filling pressures, We don't aggressively hydrate, and we hydrate based on the post-PCI hydration and EDP. Okay, here's a classic example of an ultra-low contrast angiogram on the left and a standard angiogram in a patient with advanced chronic kidney disease on the right. This is completely operator dependent. If the operator is comfortable performing these three pictures, it can save the patient significant morbidity, but this is exactly what Sunil was talking about. If you are in a fear of change, then this is what we all trained with. You'll end up doing all of these angiograms, which is clearly going to be harmful. Why do we need to do that in this day and age? This is a patient with a GFR of 8. Obviously, we've diluted the contrast. There's an ambiguous lesion, partly because of poor overlap, partly because the catheter's in the way. But now we have lots of different tools to be able to determine whether or not something is ischemic. And as a result, this is why I call this a diagnostic assessment. It's not unusual at all for us to be able to do these assessments without using contrast. These are very safe wires and determine whether there's something physiologically significant. So here's an example of a patient who underwent ultra-low contrast angiography, 2.3 cc's in the right, 3.3 cc's to assess the LAD, and 3.4 in the apicaudal to assess the circumflex. So the total result is 10 cc's. The contrast volume to eGFR ratio of less than 1. You do not pan the table ever for ultra-low contrast angiograms. This is the blueprint for your PCI. So now we have a patient with multivessel disease. There's clearly a lesion in the proximal LAD and also in the circumflex. So typically what we do is stage these procedures, especially if they're not an ACS. This allows the contrast that you've delivered to wash out. And as a result, when the patient comes back, I describe it to them as having a second paycheck. And so we can go gambling one more time, but we never go in debt with the kidneys. So in general, in patients with stable CAD, patient PCI should be staged for 1 to 2 weeks after diagnostic angiography or invasive physiological assessment. This allows renal recovery. Now, I'm going to skip the ramus for a second. I'm going to just show some of the strategies that we use in order to minimize injury to the heart. And so, for example, here you can see us wiring, and we purposefully make a lot of knuckles. By making these knuckles, these stay stable in the distal circulation. And here's another example where we're purposely trying to make a knuckle so that we can leave these in the distal arteries, and as a result, not worry about end holes from wires. Okay, so here's our reference frame. You can see this is the branch. We've got a knuckle in here. And again, in the LAD, here's our reference frame on the left, and we have a knuckle. We are in a very safe position here to be able to do PCI. The first step for us is actually to go ahead and do our measurements. So here in this example, what we're doing is measuring the distal reference, the lumen, as well as the EEL. This is a very large vessel. We're scrolling through the artery to determine morphology. This is largely a fibrofatty lesion. And so what we can do by this is determine the length of stent that we need, as well as the diameter of stent that we need. And so what we're looking from here is to identify exactly how long we need to be. And so what you're going to see here is us bookmarking and determining the length that we need in order to be able to perform this proximal LAD PCI. And so what we can do by marking the distal reference with the IVUS catheter, we can know exactly where we need to land our device. Here you can see we're marking the distal reference. The distal reference lumen is 3.81. The EL is to 5.61. So we're going to use an intermediate size. This is the IVUS at the proximal reference. You can see it's 3.53 at the lumen. This is a cine at the proximal reference, so we know exactly where we are. And then what we can do is, this is our IVUS at the proximal reference. We want to try to nail the ostium, and so we've got the marker lined up at the ostium immediately next to this, and then we can do a DS deployment. Again, this is the reference frame. This is the post-dilation. Again, the reference frame is on the side. We do IVUS marking of the distal reference. What we can then do is determine the minimal stent area. By marking the minimal stent area, we know how far this is from the distal stent edge. And in our post-PCI assessment, what we can do is look for the parts of the algorithm called MLD max. So first, what we're going to do is measure the distal reference area to determine what our target is for expansion. So we need to be bigger than 9.09 millimeters squared. We'll then scroll through the artery and look for a segment that may be smaller than that. And so we're going to end up looking somewhere here, making our measurement. And by determining this measurement and dividing this area by the distal reference area, we can determine our expansion. 9.61, so we're fully expanded. Now, one of the things that we wanted to do is to make sure that we actually got the ostium. And this is an interesting thing for zero contrast PCI because people become very concerned about not being able to place things carefully. But actually using the IVUS marker and placing it next to your cine panel actually can help you in these situations, and I believe is even better than using contrast, and it can help you actually do things like this. So here's a pullback from the circumflex, and you can see that there's virtually no struts that you can see. The circumflex is the LAD with just a few struts in the way. What about the clinical outcomes? This is a work in progress that's in preparation at the moment. You'll see in patients who have ultra low contrast angiography alone, their event rate is 17%. Those patients who also undergo PCI is 25%. And those patients who have standard of care, 48%. You can do all kinds of zero contrast PCI. This is obviously an evolution. This is one of our first rotational atherectomy zero contrast PCIs. This is actually our first or second retrograde reverse cart CTO zero contrast PCI. We actually did this live at the CTO conference in 2018. And this is a saphenous vein graft PCI using NIRS in order to determine whether there's lipid within a lesion versus not. In this example, there was lipid, so we put a distal filter in. And then you can do very complicated PCIs. This is a distal left main zero contrast PCI, again, using IVUS marking. So if you're interested to go through the exact step-by-step, you can link to our live case at TCT, which was done in 2018. And I want to thank everyone for their time.
So thanks, Yat. So that I think we have around 10 minutes for discussion, so that any question and comments will be welcome. So Ziad, so what's your indication for zero contrast PCI?
So, you know, Bon-Kwon, for us, this is, I would say, become fairly routine. So patients with an eGFR less than 30, they almost all get zero contrast PCI now. You know, this is a spectrum like anything else, no different to physiology. The lower your GFR, the higher your risk. And the argument for taking a picture at the end is really very simple. If you're not comfortable doing completely imaging and physiology guidance, take a picture. Use the 5 cc's. It's about balance of risk. I'm very comfortable with imaging and physiology. I believe I can use those cues, and the angiogram doesn't particularly add much for me. And as a result, I feel very comfortable to perform zero. And then you also need to know the risk factors for which patients are going to develop contrast nephropathy. So if you have a patient with a ejection fraction of 25% with a hemoglobin of 8, that's a particularly problematic patient. In that patient, I'd be going for zero. If you have an eGFR of 40 and the patient has a normal ventricular function, I'd be very comfortable using 20 or 30 cc's of dye. So it's a spectrum.
Yes, please, Akiko.
So I have the comment and question to Dr. Akasaka. Yes. So I think I almost 100% agree what you mentioned in terms of the calcified lesion. Mm-hmm. I think what we learned in the past 2-3 years in terms of the calcified lesion, we really understand, we have to understand the total volume of the calcium that's really related to the stent expansion. Mm-hmm. And imaging help. But also we learn when we open the OCT, sometimes the calcium is thin, and then we change our mind. Actually, we don't need the rotablator because this calcium can making the fracture. So that I think the imaging make perfect sense to do. But I think that finally, this is my question to you is really what was left in terms of the calcified lesion is calcified nodule. Yeah. And also the very eccentric negatively modeling artery. how to treat. That's, I think, we don't know well, but I think that's super important. So what your strategy to deal with the calcified nodule and what you show, yeah.
Yeah, thank you, Akiko. It is a very important question, and still we haven't, a good answer yet. Because, it is important to identify the wire position by imaging when we treat the eccentric calcium or nodular calcification, right? I have to differentiate calcified nodule and nodular calcification, okay? Calcified nodule should be related to the acute coronary syndrome, but nodular calcification is, yes, a stable coronary angina. But if we can identify the wire bias by imaging, IVAS or OCT, we can use an atherectomy anyway, if any kind of modality can pass the nodular calcification. And also, and if we succeed to, ablate in some degree, we can decide how to treat, put a stent or not put a stent, because as you know very well, under expansion of the stent is a big issue. It may relate to the stent thrombosis and also the stenosis. Therefore, if there are not enough, we do not have enough data, but if the lumen size is big, we try to put a drug-coated balloon and then leave it alone at the moment if the stent is not suitable to the region. And the negative remodeling and eccentric calcium is also the big issue. Anyway, if you want to do the ablation, it is important to confirm the wire position by imaging, and then you decide to do the ablation or not. But there are no big data, as you know very well. How about how do you think about such condition, right?
Yeah, I don't know, and we don't have an answer, but I do think the calcified nodule itself is really bad future outcome, as you show, because they are recurrent, they are reprotruding, because they have more bending portion. So possibly debulking could be better than just putting balloon, putting stent, but I have no data yet. So that's, I think we have to look more. Yeah. That's what I think.
There are only one case. They did laser ablation, and they succeed to ablate nearly completely, and then did drug-coated balloon. The result is very good in calcified nodule, right? So we have to do such kind of treatment systematically. Yeah. Thank you.
I have a small question to Ziad. I mean, about intervention without contrast. How many times do you need to check with, you need to check with angel, even if you are, your purpose not to use it? That I think.
Great question.
I think it is very important, the experience in intravascular imaging. That means you have to have a big scale in order to be based only on intravascular imaging. And I think that takes some time to be trained to do that.
So I had that same learning curve. So in my first 31 cases that we published in European Heart Journal, I was very neurotic. I did FFR, CFR, IMR, IVAS on every single case, basically in every vessel. And what I really learned from that, from the pattern recognition, is nothing happens without a second signal. If you don't have any EKG changes, the patient has no chest pain, and you don't see any hemodynamic perturbance, nothing's wrong. And so I, as a result of that, could start to drop things. So I stopped doing the CFR in every case. I stopped doing physiology in every case, and I learned this is an IVAS guided procedure. And that I learned that literally by the meticulous nature that I did the first 30 cases in. I would say at the moment, the only time we do an angiogram is if there's some sign of a complication or technical difficulty. We can't deliver the stent, or we've done atherectomy and done lots of ballooning, or things don't go smoothly. Then we'll do a little check. To be honest, at this stage, even for side branches, the pressure wires are so good, we'll just stent across and slide in the Omni wire in 2 seconds and determine whether there's a physiologically significant lesion or not. And if not, we stop. Again, even in those cases when there's a 99% pinch, for example, a carina shift, if there's no EKG changes, many operators would leave that anyway. I mean, Bon-Kwon, you have done the most work in this area on, side branch and diagonal pinching. So you should maybe help guide us in those situations. But I would say when you have developed the skills, honestly, this is exceedingly rare where we need to do further interventions.
Sunil, it's great to see the rapid increase in the use of imaging in your center, but correct me if I'm wrong, and all the rapid adaptation is due to the OCT. So that are your center using OCT only, or adapting both IVUS and OCT?
Yeah, so we're about 75% OCT, 25% IVUS. And I should mention that the adoption in our center contrasts quite a bit with the adoption overall in the United States. The rate of imaging PCI in the US is still less than 10% overall. Some of that is driven by financial incentives. A lot of that I think is driven by lack of familiarity and proficiency with the actual imaging technology. In our training programs, there is no minimum requirement to actually interpret intravascular imaging studies. There's a requirement for a certain number of echoes you have to read and a certain number of nuclear stress tests, but there's no requirement for intravascular imaging with respect to that. I think it's a huge opportunity for us to try and improve the overall adoption of imaging, starting at the fellowship level in the US.
So I just make a comment on that because we published in Sunil's journal a really interesting study where we asked the fellows whether or not they could do an imaging and physiology guided PCI, and 70 or 80% of them said, yeah, sure. Yeah, I can do it. And then we asked them the core competencies. He says, can you recognize drift? Can you recognize hyperemia? Can you, can you recognize the distal reference vessel? Can you recognize a dissection? And the numbers just plummeted. I mean, 15% of people could do an OCT guided PCI, 30% an IVUS guided PCI, and about 45% of physiology guided PCI. And on that note, when we looked at the ACGME requirements, the ACGME requirements did not mention OCT, mentioned IVUS, and said that you have to be proficient with the Doppler wire. So you can see how outdated those documents probably are, because you can't even get the Doppler wire anymore.
Okay, that's actually was also why I asked you. I think it is not enough to have IVUS in the cath lab to do anything with IVUS. I think interpretation, execution are very important also as well.
Right, so that we are talking about the very special situations, imaging physiology, but the fundamental issue may be that we should teach and we should give more efforts to penetrate this important knowledge and tools in the daily practice of the other centers. We don't care about that much about all these lecturers, great panels and speakers, but we have to care about the others who don't use, for several reasons, imaging and physiology. So it's sorry that we have to close this session for the sake of time. I really thank Dr. Park again for organizing this great session, and also for the great speakers and panelists, and also to my co-moderator, Dr. Fearon. And have a great day and be safe, and let's keep in touch. Bye-bye. Thank you.
Bye-bye, everybody.
Thank you.
Bye.